Hello friends, today we are going to discuss about sepsis associated acute kidney injury. So, sepsis in 2016, the American Medical Association released the latest definition and diagnostic criteria for sepsis, namely sepsis 3. The new definition proposed that sepsis is a life-threatening organ dysfunction caused by dysregulated host response to the infection, downplaying the hallmark of sepsis that has been used in the past uh, that is systemic inflammatory response syndrome, especially emphasizing the difference between the concept of sepsis as a severe infection and general infection. A new criteria proposed that patient with the infection or suspected infection can be diagnosed with sepsis when sequential organ failure assessment score is more than or equal to 2. Now the acute kidney injury. The 2012 KDIGO guideline defined the diagnostic criteria for acute kidney injury. Unlike earlier recommendation, the KDIGO criteria no longer require adequate fluid resuscitation and exclusion of urinary tract obstruction prior to use this criteria. The definition emphasizes the AKI risk assessment and evaluation, and while expanding the evaluation criteria to include assessment of serum creatinine of 50% or more above the presumed baseline within 7 days. However, in clinical practice, the serum creatinine and the urine output have certain limitation in the diagnosis of AKI. In animals, sepsis reduces the muscle perfusion and thus creatinine production, thereby suppressing the increase in the serum creatinine concentration and limiting the early detection of the injury. Now, septic shock develop AKI before receiving medical care. In septic shock, in septic shock, AKI may be missed. In septic shock, AKI may be missed due to dilutional effect of aggressive fluid resuscitation. Therefore, there is a call for further refinement of AKI based on changes in this traditional functional marker as well as biomarkers of the kidney injury. Now, sepsis-related acute kidney injury. Once the diagnostic criteria for both sepsis and AKI are met, a patient is considered to have septic AKI. In the ICU, sepsis is associated with up to 40% to 60% of AKI. And Saaki is associated with the 6 to 8-fold increased risk of in-hospital death and 3-fold increased risk of chronic kidney disease among the survivors. Furthermore, patients with the sepsis-related AKI have significantly increased mortality compared with patients with AKI of other etiology. Pathophysiology of the Saaki. Pathophysiology of the Saaki remains unclear mainly for the following reasons. First point is that although progress has been made in the diagnosis of Saaki, relying on the serum creatinine and the urine output has significant limitation in the timely diagnosis of AKI and cannot provide specific cause of the injury. The second point is that kidney biopsies are difficult to obtain because septic patients, especially those with Saaki, are usually in critical condition, which makes it difficult to obtain data on pathophysiological evaluation of the subject. Third point is that more than 50% of the patient with septic shock develop AKI before receiving medical care, making it difficult to determine which comes first. The underlying pathophysiological mechanism of Saki are mainly caused by inflammation, peritubular and the glomerular microvascular dysfunction, cell cycle arrest and apoptosis, metabolic response of the renal tubular epithelial cell to the injury. Now about inflammatory cascade. During sepsis, pattern recognition receptor expressed on the surface of immune cell recognizes release pathogen related molecular pattern and injury related molecular pattern, that is PAMP and DAM, and start the intracellular molecular cascade, which is manifested as inflammatory response. In addition, renal tubular epithelial cell also express the toll-like receptor, especially TLR2 and TLR4. So once this PAM and DAMP are infiltrated through the glomerulus, similar pathway are activated, leading to the increased oxidative stress, production of reactive oxygen species, and mitochondrial damage. Now, macrovascular and microvascular dysfunction. Studies have shown that renal efferent arterial vasodilation during sepsis resulted in decreased glomerular flow infiltration. At the same time, the renal arterial vasodilation and the intrarenal shunt leads to large vessel dysfunction. Large vessel dysfunction diverts the renal blood flow from the medulla to the cortex, resulting into the reduced perfusion and oxygenation of the medulla, further worsening renal function. So, tissue perfusion is critical for adequate function of any organ. Studies have shown that microcirculatory alteration occur during sepsis, even in the absence of hemodynamic instability. These observations suggest that altered microcirculation plays a critical role in the development of organ damage. Sepsis causes changes in the local microcirculatory blood flow, characterized by increased heterogeneity in regional blood distribution and the increased capillary insufficiency. Multiple mechanisms underlie this characteristic microcirculatory disturbance, including endothelial dysfunction, impaired erythrocyte deformity, damage and shedding of glycocalyx layer, increased leukocyte activation, adhesion and the recruitment, platelet adhesion and the activation of coagulation cascade, and fibrin deposition. Microcirculation dysfunction can lead to changes in the local blood flow distribution, which in turn leads to the nephron ischemia, loss of autoregulation, and exacerbate renal tubular epithelial cell damage and dysfunction. Cell cycle arrest and apoptosis. There is increasing evidence that mitochondria are closely related to regulation of cell cycle, and cell cycle arrest is an important cellular defense strategy in the context of sepsis. Sepsis can induce significant mitochondrial damage, activation of mitochondrial mass regulation process. Since one of the most energy intensive process a cell undergoes is replication. When mitochondrial function is compromised and energy supply is insufficient, cell will enter either cell cycle arrest to avoid energy exhaustion and apoptosis. Thus, during sepsis, cell appropriately downregulate aerobic glycolysis and increase oxidative phosphorylation to defend against the Saaki. Two markers of cell cycle arrest are tissue inhibitory metalloproteinase 2 and insulin-like growth factor binding protein 7 has been found to be the best predictor of Saaki. Now, metabolic reprogramming. Metabolic reprogramming is the conserved defense mechanism that cell utilizes to optimize and adjust the energy expenditure. Prioritizing the energy expenditure during sepsis is crucial for cell survival during acute phase of sepsis and may determine repair phenotype during recovery phase. Studies have shown that in the early stage of sepsis, immune cells stimulated by inflammatory signal switch their metabolism from oxidative phosphorylation to anaerobic glycolysis. This metabolic shift drives the differentiation of the T cells and monocyte towards the pro-inflammatory phenotype such as Th17 and M1 macrophage respectively. These metabolic reprogramming changes protect against the AKI and increase survival in animal model of the sepsis. Activation of the OXPHOS regulators such as SIRT1 and peroxime proliferative activator receptor co-activator alpha 1, that is PGC1 alpha, also reduces the sepsis mortality, suggesting that the OXPHOS has the positive effect on the sepsis, that is protective. Now, diagnosis, screening, and prevention. Once the diagnostic criteria for both sepsis and AKI are met, the patient is considered to have septic AKI. However, diagnosis of the sepsis is based on the SOFA score, which does not take into account underlying CKD. When evaluating the kidney system, thus cannot differentiate between new onset AKI, underlying CKD, or acute or chronic AKI. So Mehta et al. Found that 40% of critically ill patients develop sepsis after AKI. So making it difficult to pinpoint exact time of the onset of both syndromes. So based on above reasons, finding biomarkers of renal injury is of great significance for the diagnosis of sepsis-associated AKI. Studies have shown that both proencephalin and cystatin C are highly correlated with the AKI and GFR, and serum creatinine increases before severe sepsis patient. which is helpful for early prediction and diagnosis of Saaki. Studies have also shown that inhibitors of metalloproteinase 2 and insulin-like growth factor binding protein 7 in urine have highest sensitivity and specificity for prediction of Saaki. NGAL is expressed in the many cells, including prostate, uterus, salivary gland, nerve, trachea, stomach, colon, and kidney. Research have shown that even without increasing serum creatinine, the increase in the plasma NGAL have can uh, can effectively predict the risk of severe AKI in critically ill patients. When critical value of plasma NGAL of 454 Ng per ml is taken in sepsis, the sensitivity and specificity for diagnosis of AKI can reach 72% and 74% respectively. Kidney injury molecule, that is KIM1, is expressed in the proximal tubular membrane upon ischemic and inflammatory injury. Now about management, most Saki therapies remain non-specific, and early appropriate antibiotic therapy and avoidance of secondary renal injury remains the mainstay of sepsis treatment, which also prevent further renal injury. Now antibiotic to control infection. Early and appropriate initiation of antibiotic therapy is crucial to prevent AKI and reduce mortality. Delayed use of antibiotic in septic shock is associated with early AKI development. Care should be taken in antibiotic treatment and drugs that have less impact on renal function and should be used as much as possible. Use cautiously with the drugs such as vancomycin, especially when antimicrobial drugs such as piperacillin tazobactam, aminoglycoside, amphotericin B, and avoid concomitant use with other nephrotoxic drugs such as contrast media. Fluid resuscitation and vasoactive drugs. Fluid resuscitation and vasopressor are cornerstone of the septic shock treatment. For septic patient at risk of developing AKI, balanced crystalloid are recommended for resuscitation, and colloids such as albumin, hydroxyethyl starch, and gelatinine are not recommended. In septic patient, the use of hydroxyethyl starch and gelatin solution increases the risk of AKI and mortality. Clinical randomized control studies have shown that use of chloride-rich solution in sepsis increase the risk of AKI. In 2016, Surviving Sepsis campaign recommended norepinephrine is the preferred vasopressor for septic shock, which increases mean arterial pressure and improves the renal perfusion. Dopamine is not recommended for renoprotection and is associated with more adverse event than the norepinephrine. Angiotensin 2 is the potent vasoconstrictor, and sepsis causes angiotensin 2 to be relatively scarce. Angiotensin 2 infusion restores the blood pressure and increases the urine output and creatinine clearance. A recent randomized control study of the effect of angiotensin 2 in the treatment of high output shock showed that blood pressure and the reduced need for other vasopressors. Post hoc analysis of patients with AKI requiring renal replacement therapy found that 28-day mortality was reduced on angiotensin 2, and patients receiving angiotensin 2 were less likely to receive renal replacement therapy. Therefore, angiotensin 2 may be beneficial for Saki patients with shock. Now, diuretics and alkaline phosphatase. There is currently no evidence that diuretics improve or elevate the AKI. In particular, furosemide not only fails to improve AKI, but also may be detrimental to critically ill patients. Therefore, routine use of diuretics to prevent or treat Saki is not recommended. However, the utility of the diuretic in regulating and maintaining fluid balance is used for a short period of time in the treatment of critical illness with close monitoring of the renal function. Clinical studies have demonstrated a protective effect of systemic alkaline phosphatase against Saki. Alkaline phosphatase is the endogenous detoxifying enzyme that dephosphorylate pathogen and injury-associated molecular pattern, thereby reducing inflammation and organ dysfunction and improving survival. A randomized control study in patients with the Saaki showed that although recombinant alkaline phosphatase did not significantly improve short-term renal function, it significantly improved long-term renal function and reduced the 28-day mortality in patients with the Saaki. Now about renal replacement therapy. Current studies have shown that early initiation of RRT can improve prognosis of patients with the AKI. However, timing of the RRT in severe AKI patient is still controversial, and there is currently no unified treatment standard. In 2008, meta-analysis of 23 studies showed that early RRT improved survival in patients with AKI. Multiple multi-center studies have shown no significant difference in mortality between early and delayed renal replacement therapy strategy. Most current guidelines recommended that in setting of Saaki, the dose of continuous RRT should be in the range of at least 30 to 35 ml per kg per hour to ensure adequate dosing. Higher doses of RRT did not improve patient survival. Thank you, guys.